Hi, I'm Dr. Stephen Reidbord, and this is More Than Meds, where I talk about psychotherapy and psychologically informed psychiatry. And today I'd like to emphasize the second part of that tagline I always use, psychologically informed psychiatry. What does that mean? You would think that psychiatry, of all fields, would integrate the mind and the body, the mind and the brain. Unfortunately, that's not been as true as we would like. I'd refer you to my video about the history of psychiatry that in brief documents how there have been pendulum swings back and forth from physical treatments in insane asylums in the 1800s to psychoanalysis and purely psychological treatments in the first part of the 20th century, and then a shift to pharmacological drug treatments and other medical treatments in the latter part of the 20th century and up to and including now. My aim has always been to integrate these aspects, the mind and the body, not to separate them. And since most of psychiatry nowadays is very biologically oriented, it seems important to include the psychological, the mind aspects of psychiatry that sometimes get lost. In doing this, I'd like to introduce you to two terms you probably haven't heard before. The first is nomothetic, and that's a term that refers to a type of knowledge about a general principle, general law, about the world. Much of science is nomothetic. And in my field, things that we know about certain psychiatric diagnoses that are true in general are nomothetic knowledge. For example, that people who suffer depression generally don't sleep very well, and their appetite is disrupted, and they have poor concentration. Those are the kinds of principles that apply to a group of people and that help to define the disorder. This is how a diagnosis like depression is made according to my field of psychiatry, according to the DSM, the Diagnostic and Statistical Manual of Mental Disorders. This nomothetic knowledge is really the basis of much of Western medicine. It's what's made Western medicine as successful as it is, which is that we can use scientific principles and in particular randomized controlled studies to derive general principles for diagnosis and treatment. But there's another kind of knowledge, and the other kind of knowledge is called idiographic. And the idio, I-D-I-O, part of that word is from the same root as idiosyncrasy, or even the word idiot, which means a person who lives in their own world. It refers to the uniqueness of one's experience. So one can ask what generally helps depressed people, and then we could ask in a different way, do those general principles help this specific person, and to what extent do they help? Another way of saying this is that the nomothetic knowledge is that most people who are depressed feel better on an antidepressant, which is true. The idiographic knowledge is why do some people feel better and other people don't? Psychoanalysis and other forms of depth psychotherapy are idiographic. They aren't looking for general principles about people. They're trying to understand a specific patient, a specific person in an idiosyncratic way, because each of us is ultimately different and unique. So idiographic understandings of a patient, of a person, can be biological. There's a growing field called pharmacogenomics, which looks at how an individual's genetic makeup affects the way they process and respond to specific medications. But what I want to talk about here is psychological differences, individual differences psychologically in patients that might affect how they respond to a given treatment. The first question we can ask is, what is a specific patient's meaning attached to getting a diagnosis and getting a prescription from a psychiatrist? For one patient, it might mean that they have a serious problem, a problem that can't simply be talked out, but that requires medical treatment. That's a serious, heavy, concerning thing. It could mean that they have a brain disease, that this is a serious matter and that they're fundamentally damaged because they need to take something that changes their brain chemistry. Conversely, it could be a very positive message. Getting a prescription from a doctor could be a concrete reflection of the caring and the concern of the doctor. It can be a kind of gift, actually. The doctor is giving the patient something to take home with them, or even to take inside themselves by swallowing the medicine. The point is that it could mean almost anything, depending on the individual's psychology, on their own past, on the meaning they attach to the doctor-patient relationship, and on the meanings they attach to medicines in general, and that specific medicine. Some of this definitely comes from the prescriber. If a prescriber has a certain kind of attitude in writing the prescription, if they're dismissive about it, for example, that's going to very much color the way the patient thinks of the medication and the prescription. But even under circumstances in which it's a very neutral or mildly positive encounter with the doctor and the patient, still, much of the patient's meaning is going to come from themselves, from their own psychology. Now, thinking about the psychology of medication management and psychiatry takes it so far, but if we want to really get into it in a detailed way, we need to talk about the psychodynamics of psychopharmacology. Now, that is a mouthful, but psychodynamic psychopharmacology is using the principles of psychoanalysis and psychodynamic psychotherapy in the context of a medication encounter between the doctor and the patient. Think of the various psychological overtones that could be going on as a patient is given a prescription, is asked or instructed to take it on a regular basis, and to report back at the next visit how they're doing. The patient might want to please the prescriber, in which case they may say it's working great when objectively it isn't. Or as a placebo effect, maybe it is working better simply because the patient unconsciously wants to please the prescriber. They're not doing it on purpose, but they're doing it unconsciously. Conversely, the patient may want to defy the prescriber. Nothing you give me works, doc. Or potentially compete with the prescriber. That was a good suggestion, doc, but I looked up on the internet and I found a better medicine. So I'm sure yours isn't as good as the one I found. Our old friend Sigmund Freud, 100 years ago or more, came up with a phrase, flight into health, to refer to the idea that a patient will declare themselves cured, or all better, to avoid further work in psychoanalysis. But this can also happen with medication management as well. I'm good here. I don't need to take your medicine anymore. I'll be leaving now. If the prescriber doesn't think about it very carefully, that might just be checked off as a success, when in fact it isn't a success. And as we know, the relapse rates for many psychiatric complaints are pretty high. A person will again become anxious or depressed and seek treatment in the future. Some patients have a psychological need to stay ill. They identify themselves in their sick role. They're an ill person. And for psychological reasons, again, not conscious reasons, nobody wakes up in the morning saying, I'm going to spend the rest of the day being an ill person. But for a variety of subtle reasons, a person may take some comfort or some stability of their self-image in being a sick person. And that's going to push against any efforts to get better, whether those are pharmacological or psychotherapeutic or really anything else. Conversely, I'm sure there are many patients or many would-be patients out there who are psychologically motivated to never admit they have any illness or problem, even if they do. But we don't see those people. They don't come into the office. Some patients literally consider themselves beyond help. They're unhelpable. And for psychological reasons will cling to that in a way that completely defies anything that a doctor or other treatment provider attempts. This relates to a concept in psychiatry where we refer to treatment-resistant conditions, treatment-resistant depression, treatment-resistant anorexia, treatment-resistant anxiety, and so forth. And that is usually looked at as a pharmacological problem, that the search is on for a better, more effective medicine that will help people with these treatment-resistant problems. But if you look at it psychologically, treatment resistance can very easily be something that isn't really pharmacological. And last but not least, patients can use medications in unhelpful ways to avoid getting into their issues, for example, to maintain a status quo, which really doesn't work for them, to numb themselves in much the way people use alcohol or marijuana. People use prescription drugs for that too. And all of that is not only unfortunate, but a psychiatrist can unwittingly collude with this unhelpful use of the medications and actually harm the patient. The Austen Riggs Center in Massachusetts, and in particular one of their psychiatrists, Dr. David Mintz, have produced a number of books and articles on this topic in much more detail. I'll point you to this one right here, which is a 7-minute introduction to the topic of psychodynamic psychopharmacology by Dr. Mintz. And I invite you to look at his other writings and videos. Most psychiatrists don't practice a lot of psychotherapy. In the United States, it's a kind of bicoastal phenomenon, those of us who do. In much of the United States, most psychiatrists who work in outpatient settings in offices mostly focus on medication management. But there's always a role for psychodynamically informed psychiatry in all settings, even in a medication clinic or a medication office, even in the emergency department, seeing crisis cases, even on the inpatient units in psychiatric hospitals. There's always room to think about the psychology of what's going on with the patient in relation to their treater or the treatment team and the treatments that are being offered. Integrating psychodynamic or psychoanalytic understandings into all these different settings is our Jedi mind trick. It's our secret sauce. Only it's not really a trick. It's just a careful way of paying attention to what motivates people, what delights people, what scares people, what goes into a person's self-identity. It takes empathy, but empathy in turn takes curiosity, and it also takes enough breathing room, enough time to pay attention to these things. And that's why psychiatry practiced well is never fast, it's never an assembly line, it's never rushing you through. It really needs to be something which is person to person and sensitive to individuals and what is really going on beneath the surface. Well, that's it for this time. I welcome your comments and feedback below. If you like what I'm doing, please subscribe. There's always another video for you to take a look at, and I'll see you again next time. Bye.